Okay, so good afternoon once again. So today we will have our topic on inhibiting the growth of pathogens in vivo using antimicrobial agents. So for today's lecture, we will be dividing the outline into the following. So introduction, characteristics of an ideal antimicrobial agent. So how antimicrobial agents work, antiviral agents, antibacterial agents, antifungal agents, antiprotozoal agents, antiviral agents, then drug resistance, and then we will also be discussing about some strategies in the war against drug resistance, empiric therapy, and then undesirable effects of antimicrobial agents. So let us discuss first the term chemotherapy. So, contrary to many beliefs, when many people would think that when you say chemotherapy, we are just using this in treatment of the cancer. But in reality, when you say chemotherapy, um, it's actually, it literally means chemical treatment. Chemical treatment. Basically, so when you say chemotherapy, it is the use of any chemical or drug to treat any disease or condition, or utilization of chemical to treat any disease or condition, including infections. So if you are using drug to treat infection, then that is a form of chemotherapy. Therefore, a chemotherapeutic agent is any drug used to treat any condition or disease, which includes the antimicrobial agent. So, an antimicrobial agent is an example of chemotherapeutic agent because it is any chemical or drug to treat an infectious disease, either by inhibiting or killing the pathogens in vivo. Okay, so when you say inhibiting, the effect is just microbiostatic, which means that you are just stopping the growth of the microorganisms. But if a certain antimicrobial agent can kill in vivo, then that effect is said to be microbicidal. Okay. Now, some antimicrobial agents are said to be antibiotics. Now let's dissect the word antibiotics. Okay. So anti means against, bio means life. So literally, the translation of antibiotics means against life because antibiotic is defined as a substance being produced by one microorganisms that could inhibit the growth of another microorganisms. Okay, so that's what we meant by antibiotics. Okay, so in fact, um, let me tell you a story that the first antibiotic that was discovered was penicillin. It was discovered by Alexander Fleming in 1928. It was just accidentally discovered by Alexander Fleming. So penicillin is the active substance and it came from a fungus. And that particular fungus is called Penicillium notatum. So when Alexander Fleming didn't wash his plates right away, he noticed that if this is the lawn of S aureus, he noticed that there was this one um, there was this one, let's say, fungus that grows in the culture of S. aureus. And he was able to notice that this fungus, I cannot use Mary, that particular fungus was able to inhibit the growth of S. aureus. I just cannot use my eraser uh, so that you'll be able to see. So, for example, this is a fungus. So, after a while, he noticed that beside this fungus, there is a clearing zone. And that particular clearing zone is actually a zone of inhibition. Ayan. So, anyway, I have a picture pala. Later, I'll explain that to you. Okay? So, so that is antibiotics, no? So, antibiotics, a natural antibiotics was discovered by Alexander Fleming in 1928 from a fungus Penicillium notatum. So, when you say drugs, it is used to treat bacterial disease. Okay? So, drugs that you are using to treat bacterial disease are called antibacterial agents. Okay? So, we call it antibacterial agents. So, if a certain drug is being used to treat bacteria, that's an antibacterial agent. So, antibacterial agent would only be effective against bacteria, but it will not be effective against fungus because for fungus, you'll be needing an antifungal agent. If you have a protozoal infection, then you'll be needing an antiprotozoal agent. And to treat viruses, then you'll be needing antiviral agent. So that's the reason why you cannot just buy antibiotics in the drugstore without proper prescription. Because some people, especially those who do not have any medical background at all, they will just simply buy antibiotics in the drugstore without realizing that the causative agent, for example, of their common cold is not bacterial by nature, it's viral by nature. So, for crying out loud, antibacterial agents wouldn't work on anti for viral infections such as common colds. Okay, so that's the reason why we have to be prudent in using antibiotics. Otherwise, we will have problems such as drug resistance. So, this is what we defined a while ago. When you say an antibiotics, it is a substance produced by one microorganisms that could either kill or inhibit the growth of other microorganisms. So, antibiotics that have been chemically modified to kill a wider variety of pathogen or reduce the side effects are called semi-synthetic antibiotics. Okay? So, penicillin is an example of natural antibiotics. This was the one that was discovered by Alexander Fleming. However, when you improve penicillin to become semi-synthetic, then it has a wider killing capacity, such as ampicillin and carbanicillin. So, it is now called semi-synthetic antibiotics. Okay, so penicillin is a natural antibiotic. It was because it was first discovered by Alexander Fleming. And speaking of Alexander Fleming, this is the guy who discovered penicillin, penicillin in 1928. So he was working in the lab, and this is S. aureus, Staphylococcus aureus. Okay, and then his plate got contaminated with Penicillium notatum. It is an example of a mold. So what do you notice? So here, from this area, there is what you call zone of inhibition. What is a zone of inhibition? So it is a clearing zone. So this particular clearing zone indicates that the mold Penicillium notatum was able to inhibit the growth of Staphylococcus aureus. And Alexander Fleming got an idea that maybe the mold Penicillium notatum would be able to inhibit the growth of Staphylococcus aureus. So he extracted the active ingredient and he later called it penicillin. However, it was only until 1942 or several years after that the product of Alexander Fleming was manufactured in a wide scale, um, because of course it would take some time. There has to be clinical trials and all before you can manufacture penicillin as a legitimate drug. And in time for the casualties of World War, so many soldiers, many wooden soldiers were actually saved by the wonders of Alexander Fleming's penicillin. So that's how useful his discovery was. The sad thing about penicillin right now is antibiotic resistance. So more and more bacteria have become resistant to the original penicillin that was discovered by Alexander Fleming. Okay? So an unreal antimicrobial agent should be able to kill and inhibit the growth of pathogens. That's the main purpose. Okay? The main purpose is to kill, either you kill or inhibit the growth of the pathogens. And of course, you do not want to damage the host or the patient. So you only want to inhibit or kill the pathogens, but you do not want to kill the host, or you do not want to have any adverse effects to the host, such as, for example, damage of the kidneys, liver, and you do not want to have allergic reactions in the host. So, an ideal antimicrobial agent should be stable even if you stored it in solid or in liquid form. And it has to remain in specific tissues in the body long enough to be effective. So if a certain antimicrobial agent is easily excreted out and wasn't able to create a significant effect towards the host, then that particular antimicrobial agent would be useless. So an ideal antimicrobial agent should also be able to kill the pathogens before they mutate and become resistant to it. So you do not want pathogens to mutate and eventually develop resistance or drug resistance. So, how antimicrobial agents work? So, some antimicrobial agents can inhibit cell wall synthesis. So, for example, penicillin can inhibit cell wall. They can also damage cell membrane, such as polymyxin, can damage cell membrane. Some of them can inhibit nucleic acid synthesis or DNA or RNA synthesis. So, for example, rifampicin can inhibit DNA synthesis. Some of them can inhibit protein synthesis, such as erythromycin. Erythromycin can inhibit protein synthesis, and some of them can inhibit um, enzyme activity. Okay, so for example, the combination of um, sulfamethoxazole. Okay, so sulfamethoxazole can actually inhibit enzyme activity. So these are some of the actions of antibiotics. Okay, so let's discuss them one by one. No, bacteriostatic agents. So let's talk about bacteriostatic agents. So what did I tell you about the word is static? So when you say static, it will just or inhibit or stop the growth of bacteria. Bactericidal. So the term cidal, it's more powerful because it can kill the bacteria. Okay? So sulfamethoxazole or the sulfonamide drugs, the one that I gave an example a while ago, can inhibit the production of folic acid. So this particular drug this particular drug is classified under this one, the inhibition of enzyme activity. So, sulfonamide drugs can inhibit the production of folic acid. So, it's a vitamin. In those bacteria that would require para-aminobenzoic acid to synthesize folic acid. So, without folic acid, bacteria will not be able to produce certain essential proteins and eventually they will die. So, sulfa drugs are not bactericidal. So, they are merely competitive inhibitors. So, they are not, they will not even kill the bacteria. They are bacteriostatic, meaning to say if you drink sulfa drugs such as sulfamethoxazole, what will happen is that bacteria will not be able to produce folic acid. Okay, without folic acid, uh, uh, without folic acid, bacteria will not be able to produce certain protein and eventually they will die. So you do not directly kill the bacteria. So that's the mechanism of actions of sulfa drugs. However, there are some bacteria that are considered to be, or there are some antibiotics that are considered to be as antibacterial or microbe or bactericidal. So an example of this one is penicillin. So what's the action of penicillin? Penicillin will interfere with the synthesis and cross-linking of peptidoglycan. Sound familiar? So let me refresh. Peptidoglycan is the main component of cell wall. So peptidoglycan is the main component of cell wall. So if peptidoglycan is is inhibited, bacteria will not be able to form cell wall. Therefore, the action of penicillin is by inhibiting the cell wall synthesis. And if the cell wall is not synthesized, eventually this will destroy the bacteria. So what's the action of penicillin? So penicillin therefore is an example of bactericidal agent. Sulfa drugs are example of bacteriostatic agent. Okay? Penicillin is an example of bactericidal agent. So this is what the one I've told you a while ago. Drugs such as sulfa drugs um, actually mimic para-aminobenzoic acid. Since it mimics para-aminobenzoic acid, it interferes with the synthesis of folic acid. Okay. Um, there are also some classification of antibiotics according to the range in which they can have their activities or effects. No, so antibiotics or antibacterial agents can be classified as narrow spectrum, and the other one is broad spectrum. Okay, when you say narrow spectrum, it can only kill or inhibit limited types of bacteria. Limited types of bacteria only. It can only inhibit or kill limited types of bacteria. For example, we have here colistin and nalidixic acid. Colistin and nalidixic acid are classified as gram-negative can only destroy gram-negative bacteria. They are not effective for gram-positive bacteria. Therefore, colistin and nalidixic acid is considered as narrow spectrum. Okay. How about broad spectrum? So when you say broad spectrum, it can actually inhibit or kill wide range of bacteria. For example, ampicillin, chloramphenicol, and tetracycline. These antibiotics are considered to be as broad spectrum because these are destructive to both gram-positive and gram-negative bacteria. Hence, they are called broad-spectrum. Unlike colistin and nalidic acid, which could only destroy gram-negative bacteria, well, they are considered to be as narrow-spectrum. Okay. Multi-drugs, sometimes one drug is not enough. Okay? So, it's not enough, never, never, never. Okay? So, two or more drugs may be used simultaneously. So, one drug is not enough, so you have to use it simultaneously all at the same time. So, an example of that would be the drug that we are using for the treatment of tuberculosis. So, do you remember that? Are you familiar with the DOTS clinic? DOTS clinic patients would need to go to the DOTS clinic to drink the antibiotics. And if you are the community health worker assigned in that clinic, you have to supervise the drinking of the drugs. You have to see to it that the patient is indeed faithful in drinking the drugs, because once they miss it, there's a chance that antibiotic resistance could actually develop. Okay, so what are the drugs that we're using for the treatment of tuberculosis? So do not forget the acronym, right? So we are using rifampicin, isoniazid, pyra, paranizamide, and ethambutol. Okay? So these are the drugs that we are using for the treatment of tuberculosis. So this is what you call multi-drug. Okay? And we also have, aside from the multi-drug therapy, or sometimes it is known as combination therapy. Multi-drug therapy is sometimes known as combination therapy. So sometimes we are combining two antibiotics or two components to make it more effective. So if you are familiar with Augmentin, this is the brand name if you buy it from Pfizer, but the generic name is co-amoxiclab. So co-amoxiclab means combination of amoxicillin and clavulanic acid. And this combination are actually said to be effective. Now remember, if the combination is effective, we call it synergism. Okay? So synergism simply means effective combination. But technically, if we're going to define it, it is when two antimicrobial agents are used together to produce a degree of pathogen killing that is greater than the achieved by either drug alone. So if the degree of pathogen killing is greater when the two drugs are combined rather than individual drugs only, then that is actually called synergism. And synergism is a good thing. However, okay, the ineffective combination is called antagonism. So when you say antagonism, when two drugs actually work against each other, meaning to say the extent of pathogen killing is less than the achieved by either drug alone. So antagonism is a bad thing. So you really want to look into an effective combination so that you'd be able to develop synergism. Okay? So that is synergism. Okay? So that's an effective combination of two drugs. So our example here, um, is the co-amoxiclav. It's a combination of amoxicillin and clavulanic acid. Okay, so these are some of the major categories of antibacterial agents. Okay, so penicillin is bactericidal. So as what I've told you a while ago, it inhibits, interfere with cell wall synthesis. The cephalosporin groups of antibiotics, and I think we are already in the 6th gen. Okay, they are bactericidal, and it also interferes with cell wall synthesis. Tetracycline is bacteriostatic, so it inhibits protein synthesis alongside with aminoglycosides. Okay, so they could inhibit protein synthesis. So both of them have, aminoglycoside, however, is bactericidal. Tetracycline is bacteriostatic. Macrolides at lower dose and are bacteriostatic. However, macrolides at higher dose becomes bactericidal. Fluoroquinolones can inhibit DNA synthesis. Okay, so let's talk about the antifungal agents. Most of these antifungal agents work in one of three ways. So, number one is by binding with the cell membrane sterols. Okay, so do not forget, sterols, the main component, the main component of cell membrane. Number two, by interfering with sterol synthesis. By interfering with sterol synthesis. Okay, excuse me for a while. Okay, so by binding with cell membrane sterols, by interfering with sterol synthesis, and by blocking mitosis or nucleic acid synthesis. So the one that can bind with cell membrane sterol is nystatin and amphotericin B. The one that can interfere with sterol synthesis are clotrimazole and miconazole. So these are the azole derivative drugs. And the one that can block mitosis or nucleic acid synthesis is riboflavin and 5-flucytosine. Okay? Antifungal agents and antiprotozoal agent tends to be more toxic to the patient because, like the infected human, um, fungus and protozoans are eukaryotic organisms. Okay, so fungus and protozoans are eukaryotic organisms, so they tend to be more toxic to humans. Antiprotozoal agents are usually toxic to the host again because protozoans are eukaryotic. Humans are also eukaryotic. So, antiprotozoal agents can interfere with DNA or RNA synthesis, such as chloroquine, pentamidine, and quinaprine. So, if you're familiar with chloroquine and quinaprine, these are drugs that we are using for malaria. And the one that can interfere with protozoal metabolism is metronidazole. So, if you're familiar with Flagyl, Flagyl is the brand name. We are using this to treat amoebiasis. So, amoebiasis is a protozoan. So, drinking metronidazole, um, or flagyl will somehow help you from having will not totally cure you, because once you have amoeba or entamoeba histolytica, you'll always have it. Cannot really be totally cured, but at least it will alleviate the signs and symptoms of having amoebiasis. Okay, so that's flagyl. Hey, antiviral agents, okay, are the newest weapon in antimicrobial methodology. It is difficult to develop because these viruses are produced within the host cells. So some drugs have been developed that are effective in certain viral infection, but not others. So they work by inhibiting viral replications within the cell. So, for example, there is no cure for HIV, but if you are drinking, for example, antiretroviral drug, and it is being administered simultaneously, because there are several examples of antiviral drugs that are being drunk all at the same time, being taken by the patient all at the same time. So it's called cocktails. It will not really cure HIV, but somehow it will lessen the viremia or the viral load of the patient. So making the patient less infectious. Okay, so that's actually the effect of the HIV cocktails, anti-HIV cocktails or antiretroviral drugs. Okay. So the problem nowadays are the drug resistance or the superbugs. Okay. Superbugs are microbes, and they are mainly bacteria. So they have become resistant to one or more antimicrobial agents. So infections caused by superbugs are difficult to treat. Okay. So bacterial superbugs includes MRSAs. This one is the most common. Staphylococcus aureus, methicillin-resistant Staphylococcus aureus. We also have the vancomycin-resistant Enterococcus, or the VRE. And then we also have, this is also the problem, the MDR-TB. Well, aside from the MDR-TB, multi-drug resistant Mycobacterium tuberculosis, we also have nowadays the XDR-TB, extremely drug resistant Mycobacterium tuberculosis. And then multi-drug resistant strain of Acinetobacter, Burkholderia, Escherichia coli, Klebsiella, Pseudomonas, Stenotrophomonas, Salmonella, Shigella, and Neisseria gonorrhoeae. And then, some bacteria are able to produce beta-lactamase. And what is a beta-lactamase? Beta-lactamase is the enzyme that will destroy the beta-lactam ring. What is the beta-lactam ring? It is actually found as one of the molecular structure of the antibiotics. So beta-lactamase producing strains of Streptococcus pneumoniae and Haemophilus influenzae. And there are also carbapenemase producing Klebsiella pneumonia. So um, it will actually destroy carbapenems. So it's a group of antibiotics that will make carbapenems, sorry, carbapenems as as useless or resistant. Okay, so these are the things that we do not want our patients to have, because it's quite difficult to treat them. Okay, so superbugs, hospitals are notorious havens for multi-drug resistant microbes. So that's the reason why if you become a nurse in the future, if you become a nurse in the future, this one you have to, this one you have to avoid. So you have to be trained for infectious diseases, and you do not want to spread superbugs to your patients. And you do not want to get superbugs also from your patients. So how bacteria become resistant to drugs? Well, there are actually two types of resistance. So we have the intrinsic resistance, and the other one is the acquired resistance. So what do we mean by intrinsic resistance? So some bacteria are naturally resistant because they lack the specific target site for the drug, or the drug is unable to cross the organism's cell wall or cell membrane, thus it cannot reach its site of action. So this kind of resistance in, is intrinsic resistance. So let me give you an example. Our example here is Mycoplasma pneumoniae. So Mycoplasma pneumoniae is naturally resistant to penicillin. You know why? Because Mycoplasma pneumoniae doesn't have cell wall. And the action of penicillin is against cell wall. So if the action of penicillin is against cell wall, the action of penicillin is against cell wall, therefore, it cannot destroy a bacteria without a cell wall. So that's why Mycoplasma pneumoniae is resistant to penicillin, because penicillin targets cell wall and Mycoplasma pneumoniae doesn't have any cell wall. So that kind of resistance is called intrinsic resistance, which means that bacteria are naturally resistant. Now, the other type of resistance, okay, so the other type of resistance are called acquired resistance. So, if the bacteria that were once susceptible to a particular drug eventually become resistant, then that's acquired resistance. So, for example, suddenly they mutate. So, that becomes an acquired resistance. Or they got the genes for antibiotic resistance. So, that's an acquired resistance. So, the one that I've mentioned to you a while ago, these are all examples of acquired resistance. Okay, these are all examples of acquired resistance. Okay, so before a drug enters a bacterial cell, it must first bind two proteins on the surface of the cell. So these proteins are called drug binding sites. So a chromosomal mutation that can affect the structure of a drug binding site can prevent the drug from binding, resulting in a drug resistance. So it's like, the lock and key theory. If you remove the knob on the door, then the key, even if you have the key, then you'll still not be able to open the door, because the door doesn't have any knob at all, doesn't have any porthole for the keys at all. Okay, so that's the reason why that's the same analogy that we're using for drug resistance in bacteria. So to enter a bacterial cell, a drug must be able to pass through the cell wall and eventually the cell membrane. So at this point, chromosomal mutation may alter the structure of the cell membrane. So if the physical appearance of the cell membrane changes, it will now prevent the drug from entering the bacterial cell. Therefore, bacterial drug resistance will also be developed. So you do not want to change the cell membrane of a bacteria, because that way, drug resistance could actually develop. So bacteria can develop the ability to produce an enzyme that also destroys or inactivate drugs. So that's like, say, for example, um, some bacteria will be producing beta-lactamase. Some bacteria will be producing penicillinase that will destroy penicillin, or some bacteria will be producing carbapenemase, okay, that will destroy carbapenems. Okay, so that's the reason why these particular drugs will become useless, because of the enzymes, and that enzymes will eventually destroy the bacteria. So do you know that a bacteria has an extra chromosomal circular DNA called plasmid. Okay? And plasmid may contain genes such as the R factor or resistance factor. And through the process of the conjugation via the sex pili, this particular plasmid can be transferred to another bacteria. So that's how a bacteria develops resistance as well. So this particular process is called conjugation. Bacteria can also become resistant to drugs by developing the ability to produce the MDR pumps, multi-drug resistance pump, also known as the MDR transporters or the efflux pump. What does it do? The efflux pumps will actually literally pump out drugs out of the cell. So, for example, if a certain drugs will try to enter the bacteria, the efflux pumps will actually remove them away before they can damage or kill the cell. So imagine, no? So they have this mechanism called MDR pumps. So in summary, bacteria bacteria can acquire resistance to antimicrobial agents by chromosomal mutation or by the acquisition of new genes by transduction, transformation, but the most common is through conjugation. And conjugation is easily achieved by means of a sex pili. Okay, so these are the mechanisms on how bacteria become resistant to drugs. Okay, so you may want to study table 9.7 in your book. It has here the different mechanisms of action that we have just discussed a while ago and the corresponding effects. So this particular table summarizes everything that that we discussed a while ago. So you may want to study them in your book in a nutshell. Okay? So let's talk about the beta-lactamases. I've been mentioning this to you a while ago. So this is the beta-lactam ring. Okay, this is the beta-lactam ring, and this is the another example of beta-lactam ring. The beta-lactam ring is the heart of antibiotics such as penicillin and the excuse me for a while, and the cephalosporin groups of antibiotics. So penicillin and cephalosporin molecule contains a double ring structure. It's the house and garage. So this one looks like the house, and this one looks like the garage. Okay, so they call it the house and the garage, known as the beta-lactam rings. So the beta-lactam ring is the heart of the antibiotics. So which means that if these beta-lactam rings are destroyed, it will make the antibiotics useless. However, some bacteria would be able to produce enzyme called beta-lactamases. So beta-lactamase will destroy this ring, particularly when the beta-lactam ring is destroyed, the drug no longer works. So this is a sad reality, no? The drug no longer works. And there are two types of beta-lactamases. So we have the penicillinases and then the cephalosporinases. So obviously, when you say penicillinases, it will act on penicillin, and when you say cephalosporinases, it will act on cephalosporins. So drug companies have already developed special drugs that combine beta-lactam antibiotic with a beta-lactamase inhibitor so that the enzyme will not be able to destroy the beta-lactam antibiotics. Okay? So, as a healthcare worker, how do we strategize and how do we help in our war against drug resistance? Okay? So, education of healthcare professionals and patients are very important. So, do you know that drug resistance develop through through uh, unsupervised drinking of antibiotics, indiscriminate use of antibiotics, Meaning to say, for example, if the doctor says that you have to drink it for 7 days, you have to complete the drug regimen. If you'll just be drinking it for 2 or 3 days, some bacteria would survive, and those who have survived may already mutate and become stronger. And the next time around that you'll be drinking the antibiotics, that would no longer be effective for you. And worse of it, this particular patient would be transferring now the drug resistant bacteria to another person. So patients should stop demanding antibiotics every time they are sick or their child is sick. So, for example, if you have colds, do not demand for antibiotics because colds are antiviral. Antibiotics are antibacterial, so it wouldn't work. Okay? Physicians should not be pressured by patients and should only prescribe drugs only when warranted. Okay? Clinicians should prescribe a narrow spectrum drug if the laboratory results indicate that it kills the pathogens. So you do not always request for a wide spectrum. If the pathogens can be killed by narrow spectrum, then use a narrow spectrum. Patients should destroy any excess or outdated medications. So when you buy antibiotics, you buy 21 antibiotics, for example, and you have to finish that 21 antibiotics for 7 days if the prescription says 3 times a day. If the prescription says 2 times a day, twice a day lang, then for 7 days, then you have to buy 14. So that you have to ensure that these are all properly consumed by the patient. Okay? Antibiotics should not be used in a prophylactic manner. So you cannot anticipate that tomorrow I will have an infection, so now I will drink antibiotics. No, you cannot do that. Okay? Healthcare professionals should practice good infection control, and patients should take drugs in manner prescribed only by the physician. So that's the reason why nowadays, that's a good thing, no? When you go to drugstore, they will not just give you antibiotics unless you have a prescription. Okay, so let's talk about the empiric therapy. Normally, normally, when you have an infection, a doctor would request for culture and sensitivity. So for example, you have UTI. Normally, you will have to collect the urine sample and send it to the laboratory for culture. It will take um, 2 to 3 days before the bacteria are cultured and eventually identified, and eventually the medical technologies will perform sensitivity testing. And what's the purpose of sensitivity testing? So that medtechs will be able to know which antibiotics will be useful, because in sensitivity testing, you will classify the drugs into sensitive, intermediate, and resistant. And you will report the drugs, the result of culture and sensitivity to the physician. And physician will only be prescribing drugs that are sensitive. But it will take 2 to 3 days. So some doctors would be making an educated guess, meaning to say, empiric therapy can be given to the patient. So empiric therapy, therefore, is initiated, or is actually a drug therapy when it is initiated before the lab results are available. Because sometimes clinicians cannot wait for 2 to 3 days, or sa pagminsan pa nga, umaabot pa ng 5 days or 7 days before the culture and sensitivity results are actually released. It will take days. Okay? So sometimes a physician cannot wait for that, because empiric therapy is sometimes necessary to save a patient's life. So if it's a matter of life and death, you don't have the luxury of time to wait the result for culture and sensitivity. You give the appropriate antibiotics. But how would you know if it's appropriate? Well, this is where the experience of the physicians will come into play, because clinicians would have to make an educated guess based on past experiences with the type of infectious disease and the most effective drugs. Or clinicians must take a number of factors into consideration before prescribing antimicrobial agents. So, for example, he could study the most recent antibiogram study of the hospital, or the physicians can read journals. But the most common example, but the most common weapon of the physician is experience. And it says the physicians would have to take a number of factors before prescribing antibiotics to the patient. Like, what are the factors? Like the age of the patient, like the 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 condition of the kidneys or the liver. Can the patient can the patient take antibiotics because of his age, or is the patient undergoing the hemodialysis? So these are the factors, okay, that will actually come into play before clinicians would be able to make a proper prescription. But if the physician prescribed drugs even before the releasing of the result of culture and sensitivity, okay, so that's what we call empiric therapy. And it's okay for as long as you base it on you base it you have a basis when the physician prescribes a drug. And of course, the physician, after prescribing the drugs to the patient, the physicians could still wait for culture and sensitivity, and this time he would have to check whether is there a need to change antibiotics or no need to change antibiotics. Okay, so that's culture and sensitivity. That's what's happening in the clinical scenario. So, what are the factors to be considered in empiric therapy? So, if pathogen identity is known, then use the packet chart of antimicrobial susceptibility test data from the past year. So, this is what I call the antibiogram study. Is the patient allergic to any antimicrobial agent? That is very important. So, before administration, nurses would have to perform the skin testing, and that's so awfully painful. Okay, so I've been through that test several times already. And then consider the age of the patient. Also consider the patient, if the patient is pregnant or not. So the physician would also be considering whether it is an inpatient or outpatient. So normally, if the patient is an inpatient, then the physician would rather have the administration of drugs through intravenous fluid, through IV fluid, because the effect of antibiotics can immediately be seen if it's done through IV fluids. It's actually more effective. Okay, and then is the drug the hospital formulary? Okay, so when you say hospital formulary, it's actually being formulated by an in-house pharmacy. Then the site of the infection. Where is the site of the infection? And what other medications the patient is taking? Because sometimes drugs could have a contraindication with another drugs. Okay, what other medical problems that the patient have? So this is where the patients would consider the kidneys of the patient, for example. Or is the patient leukopenic? When you say leukopenic, meaning to say if the patient has low WBC count, or if the patient immunocompromised, and what is the cost? This one is very important. What is the cost of the drugs? Because drugs that are being administered intravenously are actually significantly more expensive than those drugs that you are taking orally. So this is an example of a packet chart for aerobic gram-negative bacteria. So the chart provides a quick reference whenever empiric therapy is necessary. So this chart is different from the one that you can see in the textbook, and And normally, this chart is different from one hospital to another hospital because each hospital is needed to have its own antibiogram study so that physicians would have references whenever he would be considering empiric therapy. So, what are the undesirable effects of antimicrobial agents? Okay, what are the undesirable effects? Okay, um, these are the reasons why antimicrobial agents should not be used indiscriminately. Organisms susceptible to the agent will die, but resistant ones will survive. So this is known as selecting for resistant organisms. Okay? So the patient may become allergic to the agent. So many agents are toxic to humans and some are very toxic. With prolonged use, a broad spectrum antibiotics may destroy the normal flora. So when you say normal flora, this is what you call normal microbiota, which means that these organisms are normally present, okay, resulting in an overgrowth of bacteria known as superinfection. Okay, so these are these are actually the bad effects of of too much use of antibiotics or improperly prescribed antibiotics. So which means that you really have to be careful. Really have to be careful. Do you know that some antibiotics are nephrotoxic, which means that they can destroy the destroy the kidneys. Okay? Some antibiotics some antibiotics are ototoxic. They can destroy the auditory senses. Pwedeng mabingi yung patients. Okay? So, or some antibiotics, if overdose of antibiotics are not good because it destroy those that are normally present. And there is one even bacteria known as Clostridium difficile. Clostridium difficile is actually known as the antibiotic associated diarrhea. So Clostridium difficile is known as the antibiotic associated diarrhea. Okay. So how do we know if the organisms are drug resistant? So usually indigenous microbiota of patient before antibiotics. So for example, these are these are the bacteria present in patient. So those that are S are susceptible, meaning to say they can easily be destroyed by antibiotics. So those that are R, yung green ones, are resistant. So after antibiotic therapy are initiated, those that are sensitive, died, leaving only the resistant bacteria. And eventually, these resistant bacteria will multiply. Meaning to say, now you have more resistant organism. Okay, so you do not want this to happen by drinking inappropriate antibiotics. Okay, so there you have it. Okay, so that's the end of our lesson. Okay,